All right. So once again, welcome to our general cancer group, and we're going to welcome Dr. Elizabeth Ann Bilodeau. She earned her BS and DMD and MSEd at the degrees at the University of Pennsylvania. At the University of Pittsburgh, she received her MD and subsequently completed graduate training in oral and maxillofacial pathology at the University of Pittsburgh Medical Center, earning a certificate in oral and maxillofacial pathology. Dr. Bilodeau joined the faculty of the University of Pittsburgh School of Dental Medicine in 2011. She serves as an associate professor in the Department of Diagnostic Sciences with a secondary appointment in the Department of Oral Biology. She currently serves as a co-course director for the predoctoral Oral Maxillofacial Pathology and Radiology course, the Dental Hygiene, General and Oral Pathology course, and co-directs the resident Oral and Maxillofacial Pathology course. She's board certified in Oral and Maxillofacial Pathology and serves as the UDHS Oral Pathology Biopsy Service Laboratory Director, participating in faculty biopsy service. She sees clinical oral medicine patients in the faculty practice and has participated in the UPMC Head and Neck Cancer Survivorship Clinic. She's authored over 50 peer-reviewed publications, as well as book chapters and invited articles. She serves as the Director of Education for the American Academy of Oral and Maxillofacial Pathology and has represented the American Academy of Oral and Maxillofacial Pathology by serving as a member and as a consultant member of the American Dental Association's Commission for Continuing Education Provider Recognition. Her research interests include the opathological, oh wow, this is challenging my my symbols, right? Immunohistochemical and molecular features of various odontogenic and salivary tumors. So we have the right lady here. From 2014 to 2017, she served as the University of Pittsburgh School of Dental Medicine's Director of Admissions, also chairing the Transfer Committee and serving on the Advanced Standing Admission Committee and on the Biomedical Master's Admissions Committee. She also serves the School of the on Infection Control Committee and has chaired the Academic Integrity Committee. She is a member of the Omicron Kappa Upsilon and a fellow of the International College of Dentists. So this is on my, was on one of my bucket lists to get to you guys for speakers. And this is something I really wanted. So it really sounds like I was guided to the right person. So we wholeheartedly welcome, Dr. Bilodeau here tonight. And she has some things to share. So welcome.
Thank you for that very kind introduction, probably too long. But thank you all for having me here tonight. I really appreciate it. Please feel free to interrupt me with any questions. A bit of a disclaimer, I do have some images in this talk. So please feel free to turn your eyes or turn me off for a moment or two if you don't want to see some images of the oral cavity. But I'll do my best to answer any questions that I can. My other disclaimer is that I don't practice general dentistry, but I have seen mainly head and neck cancer patients, and I've also seen what oncology care can do, particularly to the mouth. And we have tried to work pretty hard at trying to prevent some of these sequelae. And so we can kind of talk about, some of the things that we can see with oncology care. So let me see if I can share my slides here. So in theory, you should see slides. Can you all see them?
Yes.
Okay, that's a good start. So strategies to optimize oral health, particularly in oncology care. So I guess let's begin with a tooth and what a normal tooth looks like. So our teeth are hard tissue structures, and they're surfaced by enamel, which is probably our most densely mineralized structure that we have in our body. And our teeth sit in bone, and they're connected with this kind of soft tissue attachment that we talk about as our periodontal membrane. Our teeth are alive, though. Within each one of our teeth, we have nerve, artery, and vein. And this kind of attaches through the roots of our teeth into the bone. And that's a good, healthy, normal tooth. this is what it would look like in cross section. This area labeled here as C is our bone. The center here is the center of our tooth. And this is our gums up here. And then this D area, this is that attachment. And so this is what we would hope to see in health, that normal structure. Other things that we have in our mouth, well, we have our tongue. And really, if you think about it, our tongue is just one giant muscle. And it's surfaced by kind of this rough overlying tissue. And if we look at it at a higher power, here's a very healthy, happy looking tongue. And if you ever looked very closely at your tongue, what you would see is that there are lots of little bumps, and those little bumps on your tongue actually have a name, and we call them papillae. And there are different types of papillae, and they actually do serve a function. So we have these little papillae that look like spikes, and that's much of our tongue. And if we go back here, this is what they look like if we look at it under the microscope, and those were our filiform papillae. And they're rough, and they actually help us eat. And then there are other papillae that we call our fungiform papillae. And in the very back, we have these little mushroom-shaped papillae, and around each one of them is a moat. And in that moat, we actually have our taste buds, and that helps us taste. And so all of this is kind of part of the normal structures in the mouth that we hope to see in health. So one of the things that we can see with oncology care is that all of this starts to go awry, and we're more prone to kind of disruption of this normal system. And we see back here this pink, glistening, healthy, we call it mucosa, but this is the tissue that lines the inside of our mouth. And here, there's just a bit of overlying kind of surface epithelium, which is what we call this tissue. But what can happen is that this tissue starts to get thickened, and we start to get accumulation of bacteria. We start to not feel as well when we stop eating. And so this can kind of start to change, with our oncology care when we start to get that disruption of our diet, disruption of the pH in the oral cavity, increased accumulation of bacteria in the mouth. And so this is these little filiform papillae. And believe it or not, just this small roughness actually is one of the first steps that happens when we eat. And it actually helps aid in mastication, which is a fancy word for eating. And so this is what we call keratin. And a good analogy is if you think about calluses on your feet, if you ever have calluses on the heels of your feet, that's keratin. But you can also accumulate, you normally have a bit of keratin on the surface of our tongue, but you can get too much keratin on your tongue. And so one of the things that we can start to see is we start to get coating of our tongue, and then you can actually get bacteria that accumulates on top of that, and it gets trapped in here. And so that's one of the things that we're more likely to see is kind of this disruption of normal. And so kind of this is normal tongue anatomy. And what we're seeing here is increase of keratin and increase of bacteria that accumulates in these surfaces. So other normal structures that we have in the oral cavity. So we all have salivary glands. If you're able to drink right now, me talking, what enables that is our normal salivary glands. And we have pairs of glands. Here, we have the parotid, we have the submandibular glands here. Up here, we have the sublingual glands. Those are what we call our major salivary glands. And then throughout the oral cavity, and then even down, extending inferiorly, we have, or lower down, we have these minor glands. But our entire mouth is coated with these little minor glands, these itty bitty glands. But here, these are our big glands. And they basically produce saliva, and saliva is what helps lubricate our mouth. And there are all sorts of things that can affect saliva, but certainly certain medications affect saliva. And so this is certainly a common thing that we see change Certainly it changes as we get older. When we look under the microscope at older patients' salivary glands, what we see is that they are less abundant and they're more likely to be more fibrosed. But a common thing that we see when patients take many different medications is that they're going to report that they have less saliva in their mouth, or their saliva is kind of thicker or ropier. Why is saliva important? Well, it helps lubricate our mouths. It actually, interestingly, has antibacterial and antiviral properties. And so it actually secretes a certain one of our immunoglobulins. Our tooth enamel. So every time we drink something that's acidic, if we had a lemon drop candy, if I drank a soda, my pH will drop in the oral cavity. When the pH drops or my mouth becomes more acidic, what happens is it actually starts to break down my teeth. Saliva helps buffer that and helps bring back the pH to prevent the teeth from becoming dissolved. If you don't have that saliva, you're more likely to see the breakdown of the teeth every time you have a challenge with food or drink. And so they also help in that remineralization process. In order to taste something, you have to have something that dissolves whatever that flavor is. And so if you don't have a liquid that's dissolving that flavor, you can't taste it. And then the first step of digestion for like a bread is with saliva. And so there actually are, it breaks down breads with amylase, and it breaks down fats with lipase. So those are different functions of saliva, and saliva actually does an awful lot. But also if I want to eat something like saltine crackers, I definitely need that lubrication. Otherwise, if I try to eat saltine crackers or Doritos, I may end up with cuts in my mouth, and I may just not want to eat them. And I also may not want to eat because I can't taste it. So those are all reasons that saliva is very important. So diseases of the oral cavity. What can we see? Well, even outside of oncology care, these are kind of the classic things that we can see going wrong with the oral cavity. Granted, there are many others, but cavities. A fancy name for cavities are caries. So these areas here where the tooth is meeting the gum, these are big cavities. And so here, if I look at it on an X-ray, these are areas where the tooth has lost its mineralization and it's now soft. And if it's allowed to progress, eventually you're going to get an infection that it's going to extend into the bone. And then the tooth is either going to need a root canal or you're going to lose the tooth. And so it's important for a number of reasons. You're going to lose the function of that tooth. You could eventually lose the tooth, or the patient's going to be at an increased risk for getting an infection. And particularly if the white blood cell counts are low, that infection could be very serious. Gingivitis, and then periodontitis. So again, cavities. So essentially a cavity is actually an infection of sorts. You need a couple things to have a cavity. So first of all, you need demineralization of the tooth, but you also need bacteria. So we need that drop in the pH in the mouth. We need resorption of that tooth. And then we have bacteria that are involved in that process. So here we see a hole in the side of the tooth. Now, if that gets down into the bone, so if this progresses and then it involves the canal of the tooth, and then it extends inferiorly or downwards, and then it involves the root of the tooth, and then it extends outward, here you see a patient that has an abscess, and that abscess is draining outward. But if it doesn't drain outward and it gets into the bloodstream, then it can be quite significant for a patient. So if it goes untreated, it can have significant consequences. Now, gingivitis is a reversible condition. If I stop brushing my teeth for 3 to 4 days, don't floss, I will have gingivitis. Gingivitis is inflammation of the gums. And so here this patient has red, kind of, we call them boggy, swollen gums. And you can see there's a lot of plaque that are in this area. Now, as soon as that patient starts taking care of the gums, starts brushing, starts flossing, this is reversible. So we haven't lost any attachment of the tooth to that bone. So gingivitis is something that we can certainly turn around. So gingivitis, we're not past the point of no return there. When you hear the term periodontitis, though, that's where we start to lose the attachment of the tooth to that underlying bone. And so the definition is not only do we have inflammation of the gingiva, but we've lost that epithelial attachment. And so that's irreversible. So we call the outer surface of the root of the tooth cementum. And then this part of the bone here, we call the alveolar bone. And then we've got this little ligament here that we call the periodontal ligament. So you think if you bite down real hard and you kind of rock your teeth back and forth, what you'll feel is some micro movement of your teeth. So your teeth aren't fixed in stone. Your teeth have to be able to kind of rock back and forth. And what allows that is the periodontal ligament. And so that's an important kind of feature of your teeth. It's not like a screw that you have in your bone. Like a screw that goes in your bone, that doesn't have any wiggle room. That's just fixed. Or you hear about implants that go in bones. There's no micro movement there. Those are fixed. Whereas our periodontal ligament, there is this micro movement that is available. And so that's part of that function that we get with our teeth. So one thing we talk about are kind of the different phases of oral health. And so particularly what I'm most familiar with is the care of head and neck cancer patients, but philosophically, this is something that would apply in any kind of patient who's receiving care. And the first thing would be prior to treatment. One thing we would kind of consider is there a potential source of infection that could lead to a problem down the road? Now, sometimes we don't have the luxury of trying to get everything taken care of before treatment. But if we can, ideally, and this is particularly true for our head and neck cancer patients, we want to make sure that we've optimized our kind of dental status prior to implementing their treatment. So if we have a tooth that we know has a big potential source of infection, we want to make sure we take care of that. So when their blood counts drop, that's not going to be a big potential source of an infection for them that's going to make them vulnerable. And then also preventative care. So are there things we can do when they're not feeling well that is going to help prevent them from losing their teeth during or because of their treatment? And I'll talk about what some of those things are. And then during treatment, what can we do to help support their oral health? What kind of rinses can we provide? And then how can we help make the xerostomia better? Mucositis. Mucositis is a big issue. And so there are things we can do for that. And then after treatment, xerostomia may be a permanent condition in some cases. And so that's something we're going to need to manage long term. If for some reason we kind of missed the boat here, and now we have long-term cavities, then we need to treat those, but also we need to get a regimen to prevent this from being a recurring issue. If there has been radiation into this area particularly, patients can be at risk for what we call osteoradionecrosis of the jaw. So this only applies to patients that have had radiation to their jawbones. So this is a special scenario. So patients that had radiation to their jaws get treated very carefully as far as dental management goes. Also, patients that had radiation to their spit glands or their salivary glands. Any radiation that occurred to the head and neck can result in difficulty swallowing. It can also result in difficulty opening and difficulty speaking. Also, patients that have had basically anything in this area. And so these patients, there is a head and neck survivorship clinic that will work with patients for years to try to prevent these long-term consequences of the cancer therapy. Because you could start to see this trismus or these difficulty swallowing years and years out. And then restoring function. So if we've lost function, an important thing is trying to restore that function. And then kind of explaining what our rationale is and why we're going to do that. So we talked about the functions of saliva. And chemo and radiation therapy can lead to alteration in the quantity and the quality of that saliva. And so that's one thing that it's just a reality. And so if the salivary quality is affected, then we're going to try to work with that to prevent that. And so all the things that saliva does, we can start to see changes with that. So we talk about radiation caries, and this is more so when the radiation is in the head and neck region. That we can, and it's not the radiation that causes the cavities, it's that because of having radiation, patients are more likely to have dry mouth. And because of the dry mouth, they then develop cavities. So it's not the radiation that causes the cavities, it's the dry mouth that causes the cavities. So patients that have dry mouth are more likely to get cavities. So as soon as we start seeing someone with dry mouth, our concern is preventing the development of cavities. The other thing that we start to see when we see dry mouth is that patient is going to be much higher risk of developing yeast infections. Another name for a yeast infection is going to be candidiasis, but it's a yeast infection. Places we can see this, the corner of the mouth. So you start to see cracking at the corners of the mouth in this red corner. And we sometimes don't recognize it for what it is. But if you feel like there is burning in the corner of your mouth, or it's cracked and it just won't heal, that actually could be yeast. And so, you know, if you have this area and it's bothering you, actually an antifungal sometimes is what helps heal that area. We can see this yeast under, if you wear a partial denture or a full denture, we can see it developing under there. And so it's important that the denture gets soaked, it get brushed, and it not be worn too long. And then here we see this kind of white, yellow, we sometimes call it cottage cheesy material on the sides of the tongue, and it would wipe off if you tried to wipe it off. And so that's another kind of indicator that there's a yeast infection that's present, and it can burn, it can hurt, and certain foods may not taste right, and you may not want to eat them. And then particularly, so the risk factor here is dry mouth, but if particularly after somebody was put on an antibiotic, the risk all of a sudden goes higher. And so we're relatively aggressive in treating these infections. The other thing is that they have a tendency to persist, and they can track downward. So you start with a yeast infection in the mouth, it could extend down then into the esophagus. So patients, we recommend being examined prior to treatment. If a tooth isn't going to be savable, we recommend then it do be extracted prior to treatment. If a tooth needs to be restored, get a filling, we recommend fillings. If somebody needs a cleaning, it's a good time for a cleaning. But then fluoride. So you may think of fluoride as something little kids need. Well, all of a sudden now, this is a good time for fluoride again. So fluoride comes in many different forms. Now you may think, well, my toothpaste has fluoride in it, and it does, but there are different amounts of fluoride in different toothpastes. And so there are prescription toothpastes that are available that have higher levels of fluoride in them. And that might be better. That might be more appropriate to be using, like a prescription toothpaste. Just replace your old toothpaste with this prescription toothpaste, or at least use that prescription toothpaste before bed. But as opposed to rinsing your mouth out after you brush your teeth, use this prescription toothpaste before bed, and then don't rinse. And so you have kind of it in contact with your teeth overnight. All of these recommendations, though, need to be individualized based on what a patient's treatment is, what their risk factors are, how many cavities do they have, what type of restorations do they have in their mouth, how many medications are they on, what medications are they on, their fluoride varnishes, their fluoride trays. So it's not a cookbook kind of thing. It depends on the particular patient and kind of an individualized approach for every patient. And then the patient education is important. So it's important for a patient to understand kind of what we're recommending, why we're recommending it, and the recommendation could change with time. So just a few things that are out there. So Prevident toothpaste. Some patients, mint is going to bother them tremendously. And so we obviously aren't going to recommend mint. For some patients, that mint may burn. It comes in a fruit flavor. So for some, that's better. Sometimes what we'll recommend is actually varnishing the teeth prior to treatment, because it may be that they have issues with vomiting throughout their treatment. So we want to get the teeth covered prior to treatment. So this varnish comes in different flavors. And basically it probably takes about 15 minutes, maybe 5 minutes, to put it on prior to treatment. There are fluoride trays that you can put a fluoride gel in at night, put it on for a few minutes. That's another option. So there are many different ways that fluoride can be used. Some dentists have fluoride foam, and after a cleaning, they'll just put fluoride foam on your teeth, and you'll sit with it for 2 minutes. But they probably only normally use this fluoride application for their pediatric, their kids that they see. And they probably often aren't usually using it for their adult patients. But, you know, this is another time where it might be a good time to be using fluoride. So fluoride, prescription toothpaste, soft toothbrushes, electric toothbrushes. So electric toothbrushes are actually better. There's been plenty of studies that have been done. They do a better job cleaning than our good old-fashioned manual toothbrushes. And so it's just something else for you to be aware of. If you're not using an electric toothbrush, maybe it's something to think about. Mucositis can be a tremendous issue. Patients can get terrible ulcers with mucositis. And there are a lot of different approaches for mucositis. Humidifiers, avoiding sugary foods, avoid caffeinated beverages, low-level laser therapy, So mucositis is something else to be aware of. There are things that can be done for it, but patients with mucositis can get ulcers inside of their mouth. Once that happens, they're not going to want to brush their teeth. They're not going to want to touch their mouth. And so if it's severe mucositis, so that's another kind of confounding factor for taking care of your mouth during chemotherapy, radiation, oncology care. So after treatment, if there's dry mouth, and it's a lasting dry mouth, things you could do: a humidifier. For some people it works, some people it doesn't work. And so it's something to consider. Sugary foods. The reason we avoid these is high levels of sugar are going to put you at a greater risk for getting caries or cavities. Xylitol. Most of the dry mouth products are going to have xylitol in them as the component that helps lubricate the mouth. Caffeine dehydrates you, but it also makes the dry mouth worse. Alcohol, same thing. It's going to make the dry mouth worse. We will recommend getting your teeth cleaned more frequently, just to help prevent and detect issues. But also by getting that plaque off, it's going to lower your risk of developing cavities. And then fluoride becomes a forever thing if you've got serious issues with dry mouth. Some of the things that are out there, if you're not familiar with them, so biotin has a fleet of products. It's one of the most common things that folks use for dry mouth. There are a number of prescription products that are out there. Depends on whether your insurance covers them, and whether you like them, whether it's worth pursuing these. Probably one of the things that patients have the most success with once they are good at using them are these Xylamelts. They're a little odd. They have two different like sides or colors. And this tan side actually sticks up here, and you can sleep with them once you can get them in and have them stay, and they could dissolve over an hour or 2 hours. But they provide kind of extended relief for dry mouth. And you can actually put one on both sides, but you put them up on the gums and then they slowly dissolve. ACT has a number of products, and they have these lozenges. They have a mint flavored one. They also have this honey lemon one, which doesn't taste bad. And they have a number of gums. Another company has these green tea products that some people like. So there is all sorts of stuff that's out there. And what I usually recommend is try it, try them all, see what you like. There are a lot of options. So sometimes it's a matter of finding out what works best for you or some combination of them. So what about medications? So the more medications you're on, the greater the risk that the medications are also going to add to this. The biggies are going to be things like antidepressants, diuretics, but here is a list, and this is not an all-inclusive list of medications that are going to cause dry mouth. And what you'll see is that it's a pretty big list. So odds are, if you're on a couple prescription medicines, you're probably on one of your medicines, probably the side effect is dry mouth. And so if you've got dry mouth, it's probably one of the things that's contributing to it. I'm not saying to go off of a medicine, but just be aware. And in here is the oncology category. And so just be aware that this is kind of one of the consequences of treatment is that we can see dry mouth. An interesting thing though is that sometimes patients say, even though they have dry mouth, they say they have too much saliva, or their saliva feels thick or ropey. And so how do we make this better? Well, again, back to that caffeine, alcohol avoidance. And actually, if you drink more, it may make it feel better because it helps kind of dilute that saliva. Carbonated beverages actually will help make it feel less thick. And so helps break it down a bit. Frequent meals, small meals, foods that are more moist may be easier. Avoiding acidic things, also obviously a good thing. And what prevents us, though, from all of these ideal things? Well, the biggest thing for dental care is finances. Oncology care in and of itself has a lot of financial toxicity, and then dental insurance often doesn't cover the cost of care. And so that's an issue in and of itself. Sometimes providers don't feel terribly comfortable caring for patients that have had oncologic care. There may be delays in treatment. And sometimes the dentists don't want to start resuming treatment until they have quote unquote clearance. So those are all potential issues in care. Somebody asked a really great question. What about baking soda and water? And I guess I kind of skimmed over my own slide with that. But particularly if someone's experiencing vomiting, one of the best things to do is baking soda and water rinses. And what that does, the baking soda does, is it actually helps bring back up the pH. One thing we don't recommend is to brush your teeth right after vomiting. And the reason is when you vomit, the pH is going to be very, very low. So if you were to brush your teeth right after vomiting, what that can do is it can strip off the enamel essentially. And so the baking soda and water rinses, and there's no perfect formula. One suggestion that I've heard before, and I've never actually done it, but it's something I've conveyed to patients before, if you're kind of out and about, is putting some baking soda in a water bottle, and you can kind of make a slurry and use that. And so it's about finding something you want it to be liquid enough that it's still comfortable for you to rinse with. And you want it to still be palatable for you to rinse with. Salt water rinses are perfectly fine also. We always recommend warm saltwater rinses, not hot, but warm saltwater rinses. And so that also is a perfectly fine thing to rinse with. Extensive dental care, if you've got a low white blood cell count, not a good idea. If it needs to be emergent, so if you've got an active infection, you may have your hands tied. I would definitely talk to your oncologist prior. So that's why, hindsight's always 20/20. If you've got dental work that needs to be done because there is an active infection, I would do that. But I wouldn't do dental work that is elective dental work. So we kind of split up our dental work into two categories. There is dental work that needs to be done, and there is elective dental work. And so I guess I would kind of try to figure out what type of dental work is this? Is this something that needs to be done, or is it elective dental work? And I guess the other question is, what is the white blood cell count? And so I'd kind of factor that all in. And I guess here's my last slide. One Wendy probably knows more resources than I would ever dream of knowing. So I'm just going to stick here at the bottom. There are resources out there. The biggest barrier to dental care often is providers themselves. Dentists are often very uncomfortable treating patients that are in the midst of oncology care. We're just not many, our students are never introduced to this. And so if you've got a dentist right now who is comfortable with you in the midst of oncology care, consider yourself very lucky. But the other big barrier is often financial barriers. It just is what it is. Dentistry isn't covered by insurance. And so that's often a problem. There are resources out there though for medically fragile. There often are delays with them. So there is this, it's something you can check out. There is an application process, there is a delay with that. But if for those of you that have made it through care and kind of in that past care mode, that is something that is out there that you can check into. Also, there is a, they call it the mission of mercy. It's not for any big care, and it's certainly not for anyone who's currently in treatment, but for simple things like cleaning, for post-treatment folks, it is an option. I don't know if I made that clear. But yeah, that would only be for folks that are kind of past in that survivorship phase, post-treatment phase. But there are resources out there, and if I can connect anyone with resources for dental treatment, I'd be happy to try. Are there questions I can try to answer?
This was wonderful, Elizabeth. This resource list is fabulous. This is really, very comprehensive, and I know some of these resources, but it's nice to see them all in one slide together. I love that.